What if I told you that a single ABG interpretation mistake could be the difference between your patient going home tomorrow or spending 3 more weeks on a ventilator? And what if I told you that there's a simple tic-tac-toe method that makes ABG interpretation so easy, you'll never second guess yourself again? Hey everyone, it's Neil Brian Galvez of NurseBrain, and today we're tackling one of the most feared topics in critical care, arterial blood gas interpretation. Now, I know what you're thinking. ABGs are impossible to understand. There are too many numbers, and I always get confused about compensation. That's exactly what I thought when I started in the ICU. But here's what nobody tells you. ABG interpretation isn't complex. It's actually incredibly systematic. The reason most nurses struggle isn't because ABGs are hard. It's because they're taught using confusing methods that make simple concepts seem impossible. The truth is, with a right approach, you can master ABG interpretation in the time it takes to watch this video. In the next 13 minutes, I'm going to teach you the tic-tac-toe method that makes ABG interpretation foolproof. We'll cover the 4-step systematic approach that works every single time, the compensation patterns that 80% of nurses get wrong, and the clinical pearls that will make you the go-to person for ABG interpretation in your unit. I've been teaching critical care for over a decade. I've interpreted thousands of ABGs and I've seen what happens when ABG interpretation goes wrong. By the end of this video, you have a systematic method that takes the guesswork out of ABGs and gives you the confidence to make critical decisions about your patient's care. But before we dive into the method, let me tell you about a patient that showed me just how critical proper ABG interpretation really is. I had a 28-year-old woman admitted with diabetic ketoacidosis. Her initial ABG showed a pH of 7.15, CO2 of 18, and bicarb of 6. The resident wanted to intubate her immediately because her pH is so low. But when I looked at that ABG, I saw something different. I saw a patient who was compensating beautifully. Her respiratory system was working overtime to blow off CO2 and raise her pH. Intubating her would have been a disaster. Here's what ABG interpretation really tells us. It's not just about acid-base balance, it's about understanding your patient's physiology in real time. ABGs tell us if the lungs are working, if the kidneys are functioning, if there's adequate tissue perfusion, and most importantly, if the body's compensatory mechanisms are intact. Every ABG tells a story about 3 organ systems, the lungs, the kidneys, and the tissues. When you understand this story, you can predict what's going to happen to your patient and intervene before they crash. Now, here's where most people start to panic, memorizing normal values. But I'm going to give you a trick that makes this effortless. You absolutely must know these normal values, but here's the memory trick. They're all connected. Normal pH is 7.35 to 7.45. Remember, 7.4 as your center point. Normal CO2 is 35 to 45. Notice how it matches the pH numbers? And normal bicarb is 22 to 26. Here's how I remember them. 7.4 is divine. 35 to 45 keeps you alive. 22 to 26 keeps you in the mix. Silly? Yes. Effective? Absolutely. For oxygenation, normal partial pressure of oxygen is 80 to 100. The normal oxygen saturation is 95 to 100%. But here's the key. For acid-base interpretation, we focus on pH, CO2, and bicarb. The oxygenation values tell us about lung function, but they don't affect our acid-base analysis. Without knowing normal values, you can't identify abnormal ones. And in the ICU, abnormal values are what kill patients. Master these numbers and you're halfway to mastering ABG interpretation. Now, I'm going to teach you the method that will revolutionize how you think about ABGs. And it's based on a game you played as a kid. Draw a tic-tac-toe grid. Label the columns: acidosis, normal, alkalosis. You're going to place pH, CO2, and bicarb in the appropriate columns based on their values. This visual method eliminates confusion and makes patterns obvious. Step 1. Look at the pH. Is it less than 7.35? That goes in acidosis. Between 7.35 and 7.45, that's normal. Greater than 7.45, that's alkalosis. Step 2. Look at the CO2. Here's the key. CO2 is backwards from what you'd expect. High CO2 greater than 45 causes acidosis, so it goes in the acidosis column. Low CO2 less than 35 causes alkalosis, so it goes in the alkalosis column. Step 3. Look at the bicarb. This one's intuitive. High bicarb greater than 26 causes alkalosis. Low bicarb less than 22 causes acidosis. Now, look at your grid. The pH tells you the primary problem, acidosis or alkalosis. The value in the same column as pH tells you if it's respiratory, CO2, or metabolic bicarb. It's that simple. Let's say pH is 7.25, CO2 is 55, bicarb is 24. pH goes in acidosis. CO2 goes in acidosis because high CO2 causes acidosis. Bicarb goes in normal. The pH and CO2 are in same column, so this is respiratory acidosis, uncompensated. But here's where it gets really interesting and where most nurses get completely lost. Compensation is actually the most important part of ABG interpretation. Compensation is your body's attempt to fix acid-base problems. If you have a respiratory problem, your kidneys try to fix it. If you have a metabolic problem, your lungs try to fix it. The key is understanding the patterns. Uncompensated. Only one system is abnormal. pH is abnormal, and either CO2 or bicarb is abnormal, but not both. This means the body hasn't started compensating yet. Partially compensated. Both CO2 and bicarb are abnormal, but pH is still abnormal. The body is trying to compensate, but it's not enough yet. Fully compensated. Both CO2 and bicarb are abnormal, but pH is normal. The body has successfully compensated for the primary problem. Here's what most people miss. The body never overcompensates. If you see a normal pH, look at which side of normal it's on. A pH of 7.36 suggests the primary problem was acidosis. That's now compensated. A pH of 7.44 suggests the primary problem was alkalosis. That's now compensated. Here's some clinical pearl. Compensation takes time. Respiratory compensation happens in minutes to hours. Renal compensation takes hours to days. If you see full compensation, this isn't an acute problem. It's been going on for a while. Now, I'm going to show you 4 ABG patterns that should make your heart race because they represent life-threatening emergencies. Pattern 1. Severe metabolic acidosis. pH less than 7.20 with low bicarb. This could be DKA, lactic acidosis, or renal failure. These patients need immediate intervention, bicarbonate dialysis, or treatment of underlying cause. Example, pH of 7.15, CO2 20, bicarb 8. This patient is in severe metabolic acidosis with respiratory compensation. They're blowing off CO2 like crazy to try to raise their pH. Pattern 2, respiratory failure. pH less than 7.30 with CO2 greater than 50. This patient can ventilate adequately. They may need intubation, BiPAP, or treatment of the underlying respiratory problem. Example, pH 7.25, CO2 65, bicarb 28. This is a respiratory acidosis with partial metabolic compensation. The kidneys are retaining bicarb to try to buffer the acid. Pattern 3. Mixed disorders. This is when you have both respiratory and metabolic problems simultaneously. The Tic-Tac-Toe method breaks down here because you have compensating processes. Example, pH of 7.30, CO2 50, bicarb 15. Both the CO2 and bicarb are pushing towards acidosis. This patient has both respiratory and metabolic acidosis. Pattern 4. The impending crash. Normal pH with extreme compensation. This looks reassuring, but it's actually terrifying. The body is working at a maximum capacity to maintain normal pH. If compensation fails, the patient crashes rapidly. Example, pH of 7.38, CO2 15, bicarb 8. This looks okay, but this patient is hyperventilating to the point of exhaustion to maintain their pH. When they get tired, they'll crash. So how do you put all this together into a systematic approach that works every single time? Here's the 4-step method. Step 1. Assess oxygenation. Look at partial pressure of oxygen and oxygen saturation. Are they adequate? If not, this patient has a lung problem that needs immediate attention. Step 2. Determine the primary disorder. Use the tic-tac-toe method. Where does the pH fall? What's in the same column? That tells you if it's respiratory or metabolic acidosis or alkalosis. Step 3. Assess compensation. Are both CO2 and bicarb abnormal? Is the pH normal or abnormal? This tells you if it's uncompensated, partially compensated, or fully compensated. Step 4. Consider the clinical picture. ABGs don't exist in isolation. A metabolic acidosis in a diabetic suggests DKA. A respiratory acidosis in COPD patients suggest exacerbation. Remember, ABG interpretation isn't just an academic exercise. Every ABG should change your nursing care. Metabolic acidosis might mean you need to prepare for bicarbonate administration. Respiratory acidosis might mean you need to optimize ventilator settings. Compensation patterns tells you how long this has been going on and how much reserve the patient has left. When in doubt, trend the ABGs. A single ABG is a snapshot. Serial ABGs tell you if your patient is getting better or worse. That's the information that saves lives. Let me bring this back to that DKA patient I mentioned at the beginning. Because I understood her ABG pattern, severe metabolic acidosis with appropriate respiratory compensation, we avoided intubation. Instead, we treated her DKA aggressively, supported her respiratory efforts, and she was extubated. Well, she was never intubated. She went home 3 days later, neurologically intact. That's the power of proper ABG interpretation. It's not just about getting the right answer on a test. It's about making the right clinical decisions that determine whether your patients live or die, whether they go home to their families or spend weeks in the ICU. Today, we've mastered the normal values that form the foundation of ABG interpretation. Learn the tic-tac-toe method that makes acid-base analysis foolproof. Understood compensation patterns that reveal your patient's physiological reserve, identify the 4 deadly ABG patterns that require immediate intervention, and created a systematic 4-step approach that works every single time. You now have the tools to interpret any ABG with confidence. You can be the nurse who catches the subtle signs of impending respiratory failure, who recognize when patient is compensating at their maximum capacity, who makes the clinical connections that save lives. But ABG interpretation is just one piece of the clinical care puzzle. If you want to master the complete approach to respiratory failure, including mechanical ventilation, weaning protocols, and troubleshooting ventilator problems, click on the video appearing on the screen right now. Because the nurse who understands both ABGs and mechanical ventilation is the nurse who becomes indispensable in the ICU. Make sure you subscribe and hit that notification bell because we're building a community of nurses who refuse to be intimidated by complex topics. We're the nurses who break down barriers and make the impossible seem simple. Remember, every ABG tells a story about a human being fighting for their life. Make sure you're fluent enough in that language to help them win that fight. Once again, this is NurseBrain, inspiring greatness one lesson at a time.